Good morning, everybody. This is John Lee with CCSI. CCSI is one of the partners in the Managed Care Technical Assistance Center work, and we're pleased to be able to host the first in a three-part contracting series for rest of state adult behavioral health providers. And the focus of this three-part series is on contracting. And we're pleased to have with us Adam Falcone, who actually toured beginning in November of 2014, providing in-person contracting sessions. He was really well received, a great partner with MCTAC, and we're pleased to have him back. And before we get into the webinar, just want to remind people of a couple of things. Again, this is the first webinar in the Rest of State Contracting series. As we get to the end of the PowerPoint, you will see the dates for upcoming webinars. The second one will focus on some state-specific contracting expectations, and then the third part will be contracting fairs. And so you'll get the locations and the dates of those contracting fairs once we're through with the content of the first webinar. A couple of other housekeeping points. Please use the chat functionality for any of the questions you may have, and we'll try to answer as many of those questions as possible with the time that we have remaining. And of course, the slides are posted on mctac.org, and a recording of this session will be available very soon. Usually we can get that out in less than a week. And of course, any questions that aren't addressed today, we will revisit during subsequent presentations. And just a reminder that the information and the timelines that we're presenting today are as current as the date of this presentation. I imagine many of you by now know about the Managed Care Technical Assistance Center, or MCTAC. It is a training and consultation resource center developed specifically to support the needs of behavioral health providers. And it is an initiative that is a result of a partnership between OASIS and OMH to make sure that we are preparing you as providers for the transformation that's anticipated in Medicaid managed care. And for us in Rest of State, the significant date is July 1, 2016. That is when we expect this new initiative to move forward. The goal of MCTAC is really to make sure that behavioral health providers are ready for this new world of managed care, and that you have the information and the tools needed to be successful. Again, you certainly have heard of MCTAC before, but the two key leads of MCTAC are the McSilver Institute for Poverty Policy and Research, as well as CASA. They've been doing great work in supporting the needs of the provider community. As mentioned, there are also other partners that support MCTAC, including CCSI, NIAPRS, ICL, and IDEAS. And I just want to take a couple minutes to reintroduce the presenter. Again, I imagine many of you have been presented with the opportunity to hear Adam either speak live or hear one of his webinars. But Adam is a partner in the health law practice of Feidelsman, Tucker, Leifer, Feidel, LLP, and in his work he counsels clients on a wide range of health law issues. He has really used his experience to be a great resource to MCTAC, as I mentioned before, in past live presentations as well as webinars. And his area of focus for us has been around managed care contracting. And as he presents, you will see that the theme of his presentation is around negotiating with managed care organizations from a position of strength. And this is a very important strategy for behavioral health providers to understand how you present yourselves and the services you provide in a way that will allow you to get the best possible outcome of that negotiation. So again, I'm very pleased to welcome Adam as our presenter, and I will turn the presentation over to him now.
Thanks, John, for that very kind introduction, and good morning, everyone. I'm glad to be back. As you know, I've been associated with the MCTAC team, I think, for the last 2 years or so, and I always like to mention at the start that you are very unfortunate in the state of New York to have MCTAC on your side. When I do presentations to behavioral health providers in other states, they are very jealous when I tell them about the resources that are available to you, that New York State has invested in providing this technical assistance and wants to assure that the transition works smoothly, or as smoothly as possible, in Medicaid managed care. As John mentioned, this is the first of 3 webinars that are provided in this series. Today I'm going to be focusing on a sort of a refresher course on the fundamentals of negotiating managed care contracts. John will mention the other 2 webinars content at the end of today's presentation. As a lawyer, I always have to start out with a disclaimer slide that my law firm told me I had to include, but I wanted to add the additional disclaimer that my comments today are my own. They don't represent necessarily the views of the state of New York, any of their agencies, or MCTAC, or NYU, or any of the additional partner agencies. So let's get into the meat and potatoes of my presentation. If you leave today's webinar with only 1 lesson, remember these 3 simple steps: prepare, evaluate, and negotiate. So if you're the CEO or CFO for your agency, before you pick up that pen and sign the contract, make sure you do these 3 steps. Not very clever as an acronym, but it works for these types of contracts. Let's take the first step, preparation. And this is really the most important step in the entire process of thinking about how you approach managed care contracting or recontracting efforts as well. You may have heard of the book that Malcolm Gladwell wrote about David and Goliath, where he talks about the story, about the common understanding of the story of David and Goliath. He actually says in this book, we've got it all wrong. There's sort of a misconception that David, though he was smaller, he had an extreme advantage when he went up against Goliath. And that was that Goliath was expecting an opponent or an adversary similar to him, fighting similar to him, and what he found was a small shepherd boy who had a very powerful weapon, which was that the stone that he whipped around was about as strong, as powerful as a gunshot today. And he could stand for about far away and use this against his adversary Goliath. And so let's not always assume that just because you are a smaller mental health or substance use disorder provider that you are necessarily at such a disadvantage, or that you don't have advantages of your own. Part of the preparation phase is about recognizing for yourself where your leverage is, where your advantages are, so that you can achieve the most favorable provisions in the contracts with the managed care entities. As you think about preparing, think about these 3 areas of identifying strengths, assessing your leverage, then looking at whether you can compete on value, and then if you're not happy, of course, with your leverage or your ability to compete on value, then I'll offer you some thoughts and ideas for how to attempt to do that. So let's take the first element of assessing leverage, and this is really from a regulatory perspective. And in the second webinar in the series, you'll hear more detail about the New York State contracting requirements, what provisions the plans must include in their contracts with you. But you should know for any types of contracts, whether it's Medicaid, Medicare, commercial, the state has insurance laws and requirements that applies to the managed care plans. And sometimes there are favorable provisions in these requirements that give you a leg up. So for instance, here in this case, OMH and OASAF licensed and certified providers, they have to be included in the Medicaid plans network, at least for an initial transition period. and thereafter the plans must contract with generally 2 of these agencies per county. So you know from the get-go that a plan is expecting that they're going to have contracts with each of the agencies and providers, and that they have to include them in their contracts. And they know that they have to pay at least Medicaid rates, meaning APGs, at least initially in the transition period. This gets a significant amount of issues off the table for you that you don't have to worry about. You don't have to worry about whether the plan is going to offer you a contract. They're going to offer you a contract. It may not be the best contract in the world, but they're going to offer you their standard contract. And they have payment basically off the table as well, because the plans have to pay you at least at minimum payment rates that are defined by the state. So no one should have any problem accessing a contract with a plan. Now, another thing I wanted to note, because this has come up for many of you, is that the plans can't force you to participate in their non-Medicaid lines of business. So if they offer you a contract that also includes Medicare Advantage as it's called, commercial plans, exchange plans, if you only wish to participate in the Medicaid line of business, you have the right to refuse those other lines of business under the state rules. And for some of you, that's an important consideration, not because you want to turn away patients, but because in some cases the rates that they offer in those other lines of business may not be as favorable as the Medicaid rates and may not pay your costs that you incur. So in any types of contracts today, tomorrow, the next day, think about from a regulatory perspective, do I have advantages when I'm approaching that negotiation table? The next issue is sort of to look at leverage based on your market. So irrespective of whether the plan is required to offer you a contract, you should always know in going to any negotiations whether the plan needs you to meet their network adequacy requirements. You obviously have greater leverage in obtaining favorable contract provisions if the plan has no other choice but to contract with you. So even if they must offer you a contract, this is a different question. Does a plan really need you in their network to meet their network adequacy requirements? Do you need them? Do they need you more than you need them? So how do you find this out? Do your own market analysis of other agencies or providers that offer similar services as you in the counties you serve. If you're the only one, then you're going to know the plan has to have a contract with you and that you have now additional leverage to get the provisions that you want in your contracts, because the plan can't walk away from you. They need you in order to meet their compliance requirements, their network adequacy requirements. And you probably just know from sort of life out there in healthcare that if there are fewer providers in a particular region or area, then typically they have greater leverage. You know, think about the big 3 pharmacy companies out there, CVS, Rite Aid, and Walgreens. They have enormous leverage because it's really those big 3 in many markets that exist. They've really driven out a lot of the community pharmacists that didn't have a lot of leverage on their own. These big companies had a lot of leverage, and they really can't, many of these plans can't put a network together without including one of these pharmacies, if not all these pharmacies, because an employee or an individual wouldn't want to sign up with a plan where they couldn't walk down to maybe their neighborhood CVS. After you get through the market-based and regulatory leverage dimensions, think about whether you can compete on value. Competing on value really means that you bring something to the table that maybe some of your competitors don't. And this is becoming increasingly important as the marketplace shifts to a much more value-based kind of market, where the outcomes that you achieve are important to all the parties. Remember, in this case, in Medicaid, that the managed care plans are now going to be at risk for the total cost of care, both physical health and behavioral health care costs, regardless of whether a patient is in the mainstream managed care plans or a HARP plan. So this means that the plans have a financial incentive to control costs. Well, are you able to assist them in managing high-cost patients by avoiding admissions at hospitals, at inpatient psychiatric facilities, at residential facilities, at ER visits? Those save the health plan money. And if you're able to make the argument, because you have data proving it, that you're preventing some of these expensive admissions or hospitalizations, then you are certainly at an advantage in making a business case to the plans for why they need you or why they should pay you in a certain type of way. Remember, this transition period where you're guaranteed the rates and the contracts, I believe it's just for a 2-year period. After that point, those protections no longer apply, and you'll need to obtain favorable contracts really on your own merits. Some of you are already beginning the process to try to quantify in dollars and cents the value that you bring to the table. Because when those rate protections go away, of course, you'll have to argue, or you'll want to be arguing for probably higher rates, but you'll have to argue it through what you're bringing to the plan. It's not enough to go into a negotiation with a plan and simply say, you need to pay me more to cover my costs. That's a no-win argument. That doesn't provide any advantage for the plan. So think about it from the plan's perspective. Why do they want you in their network? Why would they want to have you paid in a certain way or pay you a certain amount? What can you provide them? Because this is a marketplace. There's a buyer and a seller, and you have to be able to justify either today or tomorrow the value that you're bringing to the table and how that affects the total cost of care for the population that you serve. Many of you have already started down the line of integrating with physical health care in some way, whether you're bringing that into your organization or finding some way to do some affiliations and referrals to primary care providers to ensure that your patients get the care that they need. You have to step back and recognize you do serve a very expensive population. New York has done an amazing job in studies and showing how much different populations cost the Medicaid program. And though the spending on behavioral health is a small portion of the overall Medicaid program, individuals who have chronic health conditions and mental illness cost the Medicaid program 60 to 75% more than those with those same chronic conditions alone but without mental illness. And those, of course, that have a substance use disorder are nearly 3 times higher. Well, the plans are watching those dollars being spent. And if you have a way that you can help to control the total cost of care because you also have an affiliation with a primary care provider, some kind of network of primary care where you're making sure your patients are being screened at least for primary care chronic conditions and referring them and coordinating their care, then you are probably doing a better job than someone that does not have that in place in helping to manage the total cost of care. And you're probably doing more for that managed care company than somebody that does not. But that's the kind of value that you are bringing to the table. And lastly, given the changes that are going on overall in New York State with the DSRIP program, with the PPSs, with the shift towards value-based payments, you ought to be thinking now about whether you can participate in those types of initiatives. You know, do your outcomes qualify for incentive payments from the state, or qualify the MCO for incentive payments from the state? The MCOs have a lot of rigorous data reporting requirements, and there's also a certain amount of dollars at risk for them that are based on how well they do in performing on certain quality, process, and outcome measures and managing the total cost of care. If you can help the plans and meet those benchmarks that qualify them for incentive payments, then you are more likely to get a performance-based contract yourself where you would qualify for performance-based payments over and above the rates that you're receiving for rendering services. Some of you may be in IPAs or networks or PPSs that are thinking about taking some kind of value-based payment, perhaps downside risk, or maybe upside gain, shared savings, capitation, bundled payments, a lot of the new payment methodologies that are being used between plans and providers or plans and networks. Those provide value for the plan because they put you in alignment essentially with their financial risk, and they can downstream some of their financial risk to networks or individual providers. Think about it. When you have a capitated agreement or a network has a capitated agreement with a plan, you're doing that plan a favor because now that plan has downstream significant financial risk to that network. They pay that network probably on a capitated basis, So irrespective of the utilization of services, they have basically buffeted and stopped the total amount of payments that they have to make to that network. Bundled payments or case rates work the same way, and of course shared savings and shared losses incentivize those networks or those providers to manage the total cost of care by giving those providers or networks a share of the return on that investment. Also recognize that the plans are not going to know the value that you bring without you telling them. You know, when you walk into a store, a supermarket aisle, and you see all those different brands of toothpaste in front of you, how do you know what those how those toothpastes are different from each other? Well, those manufacturers are hitting you over your head with marketing messages. Those that provide teeth whitening, those that deal with gingivitis, those that are for sensitive teeth. Those are value-based messages that they are trying to provide to the consumer. You are going to have to get to the position where you're providing those same kinds of messages. Your patients at this point are not your only buyer of services. They may just pay for a fraction of their care, and obviously you want them to choose you based on your reputation, but the person that is buying your services and paying for them are probably the plans, and you need to market your value to them for why the plan should choose you. How do you do that? It means by going to these sessions and meeting with the plans, like, for example, the ones that are planned as part of this series in person in different parts of the state of New York, and talking to the plans and distinguishing yourself from maybe other types of providers. You can request meetings with the MCOs. Each of these plans have to have clinical and medical directors, particularly those that deal with behavioral health. Nothing stops your medical director from reaching out to the plan's medical director and requesting a meeting. The plans are part of an association. Maybe you consider presenting at their conference for the value that you can bring and the savings that you can provide to plans. There's also just a number of informal networking events you might think about, or community events, where you can start rubbing shoulders with the plans and explaining who you are, who you serve, and the value that you bring to the table. Now, if you've heard me so far and you don't think you have that kind of value, that you have some work to do, you don't have to go it alone. Many providers are thinking about reaching out to other similar providers, forming networks, forming joint ventures in order to enhance their marketing leverage, to enhance the value that they can bring and offer to the plan, thereby increasing their negotiation position. There's a variety of different types of joint ventures. Some of you might be affiliating or integrating with primary care providers by different types of arrangements, referral, co-location, purchasing the services of another provider but then rendering them on your site. And some of you may even be considering the ultimate joint venture where you're considering merging with another entity to grow in size, to be larger, to provide more services to your patients, to your consumers, to offer a greater breadth of scope of services to the payer. Many of those are tactics that providers use in order to have more negotiating leverage and be able to argue that they provide better value to consumers. There's a variety of networks that have sprung up. Many in the past have heard of IPAs, these independent practice associations. One thing about IPAs is they can include whoever the IPA wants to include. Some of them include perhaps just one type of provider. Others reach out and are more comprehensive and might include behavioral health providers as well as primary care providers. All these types of networks, whatever they're called, IPA, BHO, MSO, they're all just networks where providers have decided to join together in order to achieve some business or commercial purpose. And so many BHOs may just have mental health and substance use providers, and there's also MSOs that have similar types of providers coming together. But how they're different is the services that they offer to themselves and to others. Some networks simply provide sort of back office shared support services where they're maybe the billing agent, or they're doing credentialing activities, or they're part of an HIE network, or they're providing support to providers who use the same common electronic health platform. So basically it's internal to their internal clients or customers. Other types of networks are outward looking, and they do managed care contracting. Maybe they're marketing a network. Maybe they're facilitating contracts. Maybe some of them or even negotiating contracts or shared savings arrangements. Those are actually selling services of the providers in those networks to managed care plans. Now, you don't have to do all of these activities. Some networks start out as shared savings, and once they're comfortable in working as a network together, then they gravitate and move to a managed care contracting type of network. Some today do both types. Others split them up into several separate legal entities. It's really up to the providers who are coming together to decide. But many of the smaller providers think that they have certain strengths. Maybe something that's not their strength is their billing, for example, and they want to farm that out. And rather than farming that out to a third-party billing company, they work with another group of similar providers, and they form their own company to provide that service on a sort of cost basis to themselves. So think through where your strengths are, what your core strengths are, and think about whether you do want to affiliate with other types of providers in providing some of these back office services, which are not directly involved in providing the healthcare services that you render. It's perfectly acceptable to do that. Some of you will want to jump immediately to managed care contracting. So let me say a few words about that. When providers come together and start negotiating managed care contracts, they're subject to the antitrust laws. Many of you realize that in New York State, for example, the health plans wrote to the DOJ, FTC about these big PPSs, these performing provider systems that were coming together, bringing a lot of providers under one umbrella. That is dangerous, essentially, for the competitive marketplace. If the plans only have one entity to go to buy services, then that entity really has a kind of monopoly, and they can name their price. So the antitrust laws are to encourage competition. So generally, providers can't come together and talk with others about what rates they're getting from managed care companies and negotiate together, because that would be a form of price fixing. There are certain exceptions that I'll discuss, but generally our marketplace expects providers or companies to compete against each other in order for the buyer, the consumer, and here in this case the plan, to buy services at the lowest cost that's available in the marketplace. Now, as I mentioned, there are some safety zones, some safe harbors that protect providers and allow them to come together. There's a specific DOJ, FTC statement of policy that says they're not going to go after provider networks when these provider networks are financially integrated, because they believe that financially integrated provider networks provide something of value to the marketplace, that they offer a payer or a buyer something that's more efficient than what those providers would individually do. And that's true for many capitation kinds of agreements. When you have a capitated agreement with a network, a plan is benefiting from capitation in the sense that they're paying a fixed amount to that network, and then they're basically absolved of any financial responsibility for utilization of services. So from the enforcement agency's perspective, now that network has a very strong incentive to make sure that those services are efficiently provided, because they get a single fixed price for all those services that are jointly furnished by the network. Shared savings is another kind of financial integration. If you as a network come together to negotiate a shared savings arrangement, doesn't matter whether it's upside or downside or both, you can do that as a network together, because all of you are taking that financial risk. You're all being measured together, you're all being grouped together to determine whether the total cost of care, meets some benchmark that was established by the plan, and you're working together. You either meet it together or you lose it together. Because you're all in it together, then the network, the safety zone, would protect the network in the negotiation of a shared savings arrangement. Now, there are some market share limitations. The agencies, FTC, DOJ, still feel a little bit uncomfortable if provider networks have too much market share. It's generally more than 20 or 30% of a particular market. But bear in mind that that market is measured not by the percentage of Medicaid providers that are part of that network. It's looking at the market overall. What percentage of the behavioral health providers are in that network. It doesn't matter which ones decide to contract with Medicaid plans and which ones do commercial or which ones don't accept commercial insurance at all. From an antitrust perspective, the question is, from a payer's perspective, could they offer, who's in the marketplace that they can buy services from if they were to offer enough money to those providers. So there may be a larger You may have a smaller percentage of the marketplace when you start thinking about the other types of entities out there that render similar services. There's also a sort of a quasi-exception or safe harbor for clinically integrated networks. These two offer a benefit to a plan, but this is a very hard test to meet. These clinically integrated networks typically have to operate as a single network from a clinical perspective, a common set of policies and procedures and protocols, a common EMR, managing the cost of care of that total population, ensuring that providers operate similarly and are following those protocols. And as a result, most of the networks that operate under a clinically integrated exception really have asked the FTC for an advisory opinion. Are they integrated enough in order to negotiate fee-for-service contracts? If they're clinically integrated enough, then the agencies allow those fee-for-service contracts. They don't have to be financially integrated and get paid by capitation. It's enough that they're clinically integrated and they're allowed to negotiate non-risk contracts. But I just, as a caution out there, very, very high bar to be a clinically integrated network. Clinical integration means probably something very different to the FTC and DOJ than we typically think of clinical integration in sort of common parlance today, where clinical integration is more about having providers, maybe behavioral health and physical health, offered in the same kind of setting. That's not what the FTC and DOJ are thinking about. If you're neither clinically or financially integrated, there are some non-integrated provider networks, but they can do very limited activities as a non-integrated network. The messenger is the network can act as a messenger. They can facilitate contracts between MCOs and the providers in that network, but they don't have any negotiating leverage. In a non-integrated provider model, all the messenger, the network is doing is basically facilitating that contract by offering that contract that's offered by the plan to each of their providers. Each of the members in that network have to individually decide whether that contract is good enough, whether the rates are good enough, and whether they want to participate in that contract. The messenger can't negotiate those rates on behalf of the group of providers. So limited benefit here, but it does save maybe some administrative costs for some of the providers that are in these types of networks, but they don't provide a lot of value because, again, you can't negotiate as a network if you're in a non-integrated provider network. That's called a messenger model. It's just a messenger. It's not actually a negotiating network. So as you heard, the preparation phase is the most work you have to do. You don't have to do it for every contract that passes your desk, but you should at least do it at the start of recontracting or contracting with a group or plan so that you're familiar with the leverage that you may have or you may not have and how to make sure you get the benefit from that leverage. The second step, of course, is the evaluation step. And this is where you actually look at the terms that are being offered by the plan and decide whether it fits within your goals and expectations for what should be in that contract. So here are 7 steps that you should take in evaluating the contract. Number 1, consider the time frame for review. Is the plan giving you an ultimatum, a type of deadline that you have to meet in order to be part of their network? Is that a reasonable amount of time? Why are they under that time limit? Why are they giving you that time limit? You know, if it feels like a sort of used car salesman approach where they're only offering you 24 hours to turn around that contract, that may not be a plan that really you want to work with. That does not sound like a type of partner in care. They're forcing you to accept their terms without adequate time to do your due diligence to evaluate the contract. So make sure you have enough time. If they're not offering you at first, in a week or 2 weeks, however much time you need, then the first thing to negotiate is the time frame that you have for review so that you have a reasonable amount of time. Second, think about your contract review team. Who is going to be part of your internal review process for evaluating the contract? It may be a good idea to have a manager or a point person. That is the person that is going to be your team lead, and maybe even that same person will be the lead negotiator with the plan so that they have one person in common. Now, your team may have to have a broad group of people on it because these contracts affect a lot of what you do. They affect finance, they affect clinical, they affect operations. So you may think about your team having different departments or different aspects of your operation represented. Maybe it has your medical director, your clinical director, your finance director, your operations director. And you may want to break up the contract so that each of you is reviewing the part of the contract that relates to your department or what your expertise is. That's fine. You don't each have to review the contract. As a lawyer, I have to review the contract. It doesn't mean that you have to review, each of you review the whole contract, the whole contract, as long as the whole contract is being covered at least by somebody on the inside. Some of you will get, as you get acquainted with these contracts, you'll see that they're structured in many cases the same way. It doesn't matter what plan is offering you a contract, they follow a similar format and structure. And so, for example, if you're chief financial officer and you've reviewed one contract, that's probably the most time you have to review is in your first contract that you review. The subsequent contracts will take less time. You may even be able to develop your own checklist of things that you look at within those terms of that contract. You may look at, for example, not just the rates, but whether the plan can recoup overpayments from you, whether they have to notify you when they're doing recouping an overpayment, whether you have the opportunity to object to recoupment of an overpayment because you disagree whether an overpayment occurred. You may want to have the ability not to object, and maybe you don't want the plan to do an offset of your current revenue to take that money back because it will mask it and you won't actually hear about it. So there are types of issues as a CFO that you might be very interested for how the money changes hands and whether the plan can take the money back from you. When a plan offers you a contract, do make sure it includes the entire contract that you need. From time to time, you'll be missing an exhibit or it won't be completely filled in. That's not because the plan is trying to prevent you from seeing the whole contract. From a plan's perspective, remember these have a lot of moving pieces. You know, you're just one type of provider that they have to contract with, and they may have to pull in different exhibits based on the kind of provider. And so they're pulling different pieces together. It may not include a piece that they need. You may have to go back to them and say, hey, I'm missing Exhibit C, or Exhibit C isn't completely filled in. If they refer to other documents or other things are incorporated by reference, like the policy manual or the provider manual, that may be something that you want to see, because being incorporated by reference means that that becomes part of the terms of the contract that you're agreeing to. Many plans include their provider manuals now online, and you can simply go online and look at their credentialing requirements, or look at their prior authorization requirements, or any other of the requirements that you want to look at in detail to see how the plan will relate to you. Sometimes the plans, or very typically the plans, they don't know your scope of services. Maybe they don't realize that you provide both substance use disorder services and mental health services, that you're an 822 or this type of provider, a residential provider. You have to tell them so that they include the right set of rates in the back of the contract for the right services that you're providing. So do scrutinize those exhibits to make sure that they are as comprehensive as the services you provide. Because generally, most of you will want to get paid for everything that you do and not have things that are left out not get paid. And then there may be things that you want to look at so that you can evaluate the contract, such as the plan's contract with the state. That's called a model contract. That can give you a leg up in understanding what obligations have to be passed back down to you. And if you want to know the website for those model contracts, it was on one of the prior slides when I talked about the first slide about negotiating leverage. Next, number 4. Assess the MCO's operational performance. Not every MCO is the same. Some have a reputation for moving through, credentialing through quickly. Others don't. Some have a reputation for making their payment obligations. Others don't. Every plan has their own personality, their own reputation, and that's an important thing to consider. Because if you're working with a plan that frequently denies claims that should be paid or doesn't provide you the authorizations you need, then that might affect whether you want to contract with them or what rates you want to get, because you might not get paid on all the services you provide. So think about their operational performance as a partner. And they also influence the terms that you specifically review in the contract as well. And you might want to tighten up if the plan has any particular shortcomings. Oops. The other aspect to look at is their financial performance and financial sustainability. If they're a plan that's new to the market or a plan that's weak because they don't have a lot of reserves, then that would mean that if the plan gets into hot water, they may not be able to pay all their claims. There's a number of cases across the country where plans just go bankrupt, and the providers that had claims pending with that plan don't get paid all the dollars. They get paid pennies on the dollars. So some clients decide they're not going to contract with all the plans if they feel that one is particularly weak or unstable. They don't want to take that risk. 6, we get to actually reviewing the terms of the contract. So here you want to actually make sure you know what you're agreeing to. Sounds basic, but you should understand these provisions. You know, what scope of services is the plan talking about in the contract? Do they allow subcontracting arrangements? Many contracts that I review prohibit a provider from subcontracting arrangements. Well, that could be a problem. If you hire a psychiatrist who comes in part-time under an individual contract and you're billing for that practitioner services, well, that's a kind of subcontract. If your plan with a contract with a managed care company doesn't allow you to have a subcontracting arrangement, then that may be a term that you need to negotiate. And typically, most of them will allow you allow that to happen and modify their terms. They just want to make sure that you are going to be responsible for paying that provider, and that provider will be separately billing them for services as well as you, because they only want to pay once. So the term of the provision of the contract may need to be modified a little bit. There are going to be terms that relate to credentialing. There are going to be terms related to access standards, utilization management. Some of these contracts have regulatory penalties, meaning that if the plan is penalized, they want to pass that down to the provider. You have to consider whether you want to have those penalties or whether you want to have protections written into those provisions. Some of you may want to waive co-payments or deductibles for patients who have financial need. That term might have to change in the contract. Many plans prohibit providers from waiving or reducing co-pays that would normally apply. You may want to look at whether the plan has your state prompt pay law incorporated by reference, whether New York State law is going to apply to any disputes, even if the plan is owned by a corporate parent in another state. The plan's right to suspend your payments or recoup overpayments, breach, termination, how long the term is. All of these provisions, you should understand what they mean and how they affect your organization. Does the contract include all the exhibits that you need? Does it refer to the policies and procedures that are referenced in the contract? Are they consistent with your other obligations under federal and state law? And ultimately, do the payment rates reflect fair payment for the services you do? And it would reflect sound business judgment to accept the terms of the contract. Probably not all of the terms will be favorable, and you have to identify and prioritize. As you can imagine, in any kind of contract negotiation, any kind of negotiation at all, you're not going to win on everything that you want to see changed. You're only going to win on some. So it's helpful to decide at the outset which are those key critical issues that without addressing, you simply cannot afford to proceed because the risks, which may not just be financial, are simply unacceptable for you as an organization, as stewards of your organization who are responsible for ensuring its sustainability. Maybe there's some issues that are significant but are not critical, so color code them in yellow. And then maybe green are issues that ideally would be addressed but are not absolutely essential. And this is important as you think about going to the negotiation table, because I can assure you from my experience, if you simply redline a contract from a plan and you have 40 or 50 issues that you've identified, and you send that contract right back to the rep, and they open up that document in Word, and they see red all over it, they may think twice about whether they even want to invest the amount of time of contracting with you, because that sounds like a lot of work on their part to deal with. So focus it on the most important issues at the outset. It doesn't make sense to probably look at some issues if you don't have your key critical issues addressed. Once you know that those can be addressed, then you might be able to move on to some of the less important issues. The last phase is negotiation, and I think a negotiation has a bit of a bad rap. Negotiation is simply a kind of discussion. It doesn't have to be adversarial. There's just two parties. They're trying to reach agreement on the terms of a contract. So some common missteps in negotiation is negotiating over positions, where you get stuck, where you say, I want to see a provision that says this, and the other party says, I want to see a position that says this. That's not a good negotiation. When each party take extreme positions at the outset and then try to find a place in the middle, that's not really an effective negotiation. Neither one of you are really communicating about what you need and why. It doesn't address the initial underlying concerns of the party. Those of you who have heard me before know I always give the example of a librarian with two library patrons who are arguing about how open a window should be. One wants the window all the way open, one wants the window all the way closed, and they keep fighting, going back and forth, and even in the middle, it doesn't seem to be satisfying either one of them. So the librarian walks over to the patrons and says to the first one who wants it open, why do you want the window open? And he says, because it's really stuffy in here. And she says to the other, why do you want it closed? And he says, because it's really drafty in here. So she walks over to an adjacent window some feet away from them, and she opens that halfway. Meets both of their needs, gets the air into the room, but doesn't create a draft. So it's helpful always to understand the underlying concerns. It's never a problem to say to a plan, why do you have this provision, in this contract? Why is this indemnification provision only affecting you and not affecting me? You can ask these questions in a very non-adversarial way. In fact, it's the best way, I think, really to negotiate contracts. Why do you have this provision? Can this provision apply and protect both of us? What's this mean? It's okay to do that. It's done in a non-adversarial way. It does it as an open-ended question. And most importantly, you learn from the other side why they have that provision in the contract, what interest of theirs they're trying to protect. And just like you may not know that interest, the plan doesn't know your interest. So you need to communicate back to them why that provision, as written, doesn't protect an interest of yours. And maybe there's a way to find a middle ground that protects both parties. So going back to my example where you have a provision in the contract that prohibits subcontracting arrangements. They prohibit it because their interest is that they don't want to be billed twice, once by the provider that you contract with and once by you. So they just prohibit altogether the subcontracting arrangements. After you explain that you have a psychiatrist that you individually contract with that provides a scope of services that you bill that is important to your customers, and explain that need, that is communicated to the plan, then they may be able to find a way to adjust the provision that allows you to subcontract, that ensures that you are responsible for paying that psychiatrist and prevents that psychiatrist from billing this plan separately. As a result, you both get what you need. You get to subcontract, and the plan gets the protections that they're looking for by that contract, by that provision. If you can't get all the things that you want, you have to decide whether these critical issues have not been addressed and whether you absolutely need to contract with this particular plan. In New York State, more than any other states, I think, you have more plans to contract with. In some regions, 7, 8, 9, 10 different, 11 different plans to contract with. If you can't get a contract that meets your critical issues, you need to take a step back and ask whether you can walk away from that payer. And sometimes just the threat of walking away will have that plan reconsider, because while you didn't realize at the outset that they can't live without you, they can't live without you, and they may be more flexible. You have to decide for yourself whether the risks are going to be a proceeding outweigh the risks of not contracting with that MCO. And usually you think about the financial and the legal risks involved in accepting the contract, and what the result would be if you said no. Will you lose patients, or will your patients just move to other plans that you do contract with? What are the actual repercussions that are going to happen if you don't contract with one particular plan? So I boiled it down to my Elvis suggestions. Number one, educate. Don't assume the MCO knows what you provide and understands your concerns. You have to educate them. 2, don't presume the other way that you know what the MCO is trying to protect and what their interests are. So ask them. Rather than making statements about the position you want on a provision of the contract, ask them about their interest in that provision. And ask them if there's ways to respond to their concerns but have a different type of provision in that contract. Identify ways to make it work for both parties. You may have to be the one doing the creative work to a middle ground that works for both parties. Find a way to link your provisions to objective standards. For example, I don't like payment provisions that reference the plan's fee schedule. Well, a plan can change its fee schedule anytime. I think it's much smarter to have an objective standard where the reference is to the Medicaid fee schedule or the Medicare fee schedule, and the plan is paying a percentage of that. That way, as those fee schedules increase, your revenues and your fee schedules increase as well, and the plan can't just indiscriminately change the fee schedule at any time. And lastly, do state the importance of maintaining a relationship. I do know that sounds a little bit Pollyannish, but it is important to emphasize that you want to be part of the plan's network, that you see yourself as a partner with the plan, and that you want to have this as a long-lasting relationship. It does actually help in the contract negotiations, and it sets the right tone. So a few final thoughts before I conclude and take some questions. Number one, think about your position in the marketplace. You are now a market participant. You may have competitors, you may not. You have a scope of services. It may be too narrow, it may be too broad, but think about what you're providing to the buyer of those services, the plan. Think about what your strengths and weaknesses are that when you're going into the contract negotiations. What leverage do you have by law, by regulation? What leverage do you have simply by your market position, by the percentage of the marketplace you have, by the fact that you're the only provider or one of two, and the fact that you maybe have something different and you can compete with other organizations on the basis of value. Given the choice between two providers, the plan would want to contract with the one that provides them the most return on that investment. If you're not happy with those things, think about what strategies you want to commit to in the next year or two in changing your leverage in the marketplace. Ways that you can increase your leverage by joining other networks, by broadening your services, by having a broader scope of services, by integrating, by merging, by affiliating with other types of providers, by looking for ways you can involve yourself in value-based payments, shared services, shared savings arrangements, whatnot. You have to think about the ways that you can contract with the plan in a more favorable way. And lastly, don't be shy about initiating conversations with the MCO. Don't wait for them to knock on your door. You can go out and knock on theirs. They're making themselves available to you. Right now, they may just be focused on contracting with as many providers as they can to meet their network requirements. But in the future, they may be open to different payment methodologies that support your services, but overall lower their overall costs. So start to think creatively about how you want to be paid for the services that you render in a way that benefits both parties mutually. All right, I've reached the end of my slide deck, so I'm going to turn it back over to John.
Adam, thank you very much for that great presentation and a refresher for many of us about how to negotiate contracts with managed care companies from a position of strength. Before we move into the question and answer part, I just want to again remind folks that the PowerPoint and recorded version of this presentation will be out on the MCAC website. Again, the recorded version may take up to a week, but it will be there. Also, as we mentioned earlier on, Adam had been touring New York State in late 2014 and 2015 with an extended version of this presentation, again, focusing even more time on how to successfully negotiate contracts. So if you're interested in actually seeing a recorded version of what was a live presentation, you can go out to the MCAC website and see that as well. And as I recall, that presentation probably took 2 to 2.5 hours, so there's a lot more detail. What I will say is I was listening to Adam's presentation. He did update what he shared with us based upon, the changes that continue to take place in New York State, including the focus that the state and the district initiatives are placing on value-based payments. So I want to thank Adam for doing that. So there's additional resources if you're interested. Again, this was meant to be a refresher because there was an investment in giving Adam the opportunity to tour the state earlier on. But in addition to this refresher webinar on contracting with managed care companies from a position of strength, there will be a second webinar taking place on February 17th, and that really is to focus more specifically on New York State timelines and state expectations and protections. So please join us then. Also, there is a series of in-person contracting fairs that we mentioned earlier on. The first one is taking place in Buffalo on February 29th, and what we're doing, we've extended invitations to managed care companies that have been designated to provide services in these regions. We've shared with them which counties should be covered in each of these locations and are expecting that they will attend, have tables, and be available to chat with providers. The contracting fairs go from 9:30 to 12:30 in each of these locations, with the exception of one that is in the afternoon. But what you really need to do is go out to the MCTAC website and register for the contracting fair or fairs that you would like to attend. And you'll also be getting more information about what to expect in those contracting fairs. Also, you see on the slide the dates for utilization management and billing in-person events that are going to be taking place across the state. So you will be given opportunities to register for those as well. So that's the housekeeping. And now we do have a few minutes, I'd say maybe 5, to answer a couple of questions. So I'm going to review those questions. And again, those that we don't get to, we will try to follow up and get answers to you at a later date. So the first question that was asked was, I thought joining networks for the purposes of gaining clout in negotiating contracts. We're against antitrust. Again, I believe that was answered before. Adam went into slides 24 through 27 and answered that, so I think we're all set. The next one, Adam, it's a longish kind of question because it does have a couple parts to it, but I'll read it for you. So one managed care organization includes a reference to a rate sheet in their contract, but will not provide a copy of the rate sheet or ACT, PROS, etc. when requested. Rather, they've advised the provider that the APG rates will be paid in accordance with the language that identifies that they are required to reimburse provider by these applicable plan contracts and any applicable federal or state statute regulations. However, they will not remove the reference to the rate sheet from the compensation language as there is no rate sheet, so they won't remove it from the contract. Should this be a concern? Should this be a concern, and what would you recommend that this agency do?
Yeah, I think what you've come across is the fact that plans have their form contracts, and it's difficult to change them, or they're not inclined to change them after they've gone through the process of going through their own legal review, as well as many cases approval by the state as well. It probably depends in this case exactly how the language is written in regard to what rates apply. If it's very clear, I would say that the rates that apply are the APG Medicaid rates, then it doesn't seem to me so important that the rate sheet is absent or doesn't say the specific rates in the rate sheet. Many plans do have compensation exhibits, and even if they have a set of commercial rates in it, I've seen some plans have a line at the beginning or sometimes at the end, which they say for the Medicaid program, the EPG rates will apply. That gives me confidence that irrespective of what's even in the rate chart or the rate sheet, we know that the plan is going to pay based on the APG rates. So it may not actually matter what's in those rate cells. It all is going to depend on how the contract references what rates apply and then what other language is in that rate exhibit.
Thank you very much, Adam. Yeah, thank you. So next question, when Medicaid increases their APG rate, is there a time frame when we as a provider could expect the rate increase to occur with the managed care companies?
That's a great question. It's certainly a question you should ask at the next webinar about whether there's a state requirement and how quickly the plan is obligated to reflect your new higher rates or change in rates in their payments to you. I definitely have seen language in plans contracts with providers that says when the new rate starts. In some cases, the plan says the rates start when the provider provides evidence of the new rate to the plan. And then maybe it starts at the next calendar month, or maybe there's 30 days that go by. So you need to look at both whether there's a state requirement that tells the plans how quickly they have to apply the new rates, as well as whether there's something in the contract itself that addresses that issue. But the timing issue is an important one. Typically, it is addressed, and typically I see that timing issue addressed in the rate exhibit when there's a reference to, paying on the APG, or there's usually that exhibit that indicates how new rates will update the rates that they pay you.
Thank you, Adam. I'll ask you one last question, and then we're really out of time. I'm sorry, Adam?
I didn't say anything.
Okay. What position or function should attend the in-person contracting fair? CEO, COO, finance, clinical, all of the above. What's your recommendation, Adam?
I think that might be a question I might bounce back to the MCAT team. I think I would say that if you've never sort of interfaced and been to one of those fairs, I would encourage you to come regardless of what role or title you have at your agency, because I think it's important for you to see the dynamic and see that see yourself with, who your competitors are essentially, and see what the atmosphere is like with the other plans and hear what they have to say. So I think probably, at least for these fairs, if you haven't been to one before, I'd encourage you to go.
Yeah, and thank you, Adam. And one thing that I would add is certainly if you should identify someone that will be taking the responsibility for that contracting process and make sure minimally that they attend. So we are out of time. We want to thank Adam again for a great presentation, and I want to thank everybody that participated. There are a couple of questions that we did not have time to answer, and we will follow up ourselves with those. They actually did seem to be a little bit more New York State specific. So again, thanks everybody. Don't forget to look on the MCTAC website for recorded versions of this presentation, as well as to register for the contracting fairs. And hope everybody has a great morning and rest of the afternoon. Thank you.